really one. Gloria, can you put the slides up, please?
Sorry, Alan. Bear with me one moment, please.
That's okay. Hi, Katie. As I was saying, I think what we're going to try and cover today is quite a lot of information on FIT and try and bring some clarity into what FIT is all about. We've got David James, who's the colorectal CAG lead for the Thames Valley Cancer Alliance, who's going to talk a little bit about the guidance. We're going to have some facts and figures and data about it. We're going to talk a little bit about using FIT in primary care and safety netting. And of course, what we want to do is we want to make sure it's an interactive session so that everyone gets a chance to ask their questions, which makes their life a bit easier in a sense to understand and what's going on. I'm a GP in Bracknell, the center of the universe, Bracknell, as you all know. And I'm also the Thames Valley Cancer lead, primary care lead, and a CR UK GP, dabbling a little bit in end-of-life care as a specialist as well. But anyway, let's quickly go on to David James, who's going to talk a little bit about colorectal cancer. So over to you, David, and thank you for coming along today.
It's an absolute pleasure. Thank you very much for the invite. As Alan says, I'm David James. I'm a colorectal surgeon. I'm a consultant here in Oxford, and I'm also the CAG lead. So it's great to have this opportunity to present to you all. And so, as you've been over, I'm going to talk a little bit about colorectal cancer, but then the main focus here is on FIT. So a little bit of background. So colorectal cancer, 4th most common cause of cancer, and it's the 2nd most common cause of cancer death. So males have a 1 in 15 lifetime risk, females have a 1 in 18 lifetime risk. And I think some of these statistics are just quite useful because you will often have people come to you saying, yeah, but my grandfather had bowel cancer and, you know, I'm at risk. And whilst we've always got to take these sort of concerns seriously, actually with 1 in 17 of the population having a lifetime risk of it, this is quite a common thing. So I think that's useful that you can tell your patients. Next slide, please. The incidence, as we know, it increases with age. So over the age of 50, you're looking at seeing about 90 to 94% of the cases. But we are worryingly seeing a sort of an increase in younger patients. And I think probably over the next 5 to 10 years, we'll probably start to really understand that a lot more about what exactly has gone on, what's going on, and what are the sort of epidemiological and genetic reasons for that. Really, why are we here? What's the point of doing testing? And I mean, the focus is not about screening, but the whole point of these things is trying to get early diagnosis. So with every cancer, it stands to reason, early stage, better outcome. You get better survival. You're more likely, and this is on a sort of a practical level, a patient outcome level, you're more likely to have a keyhole operation. So robotic, laparoscopic in early stage cancer. And also we still see 14 to 30%. There's quite a variation geographically across the country, but there's still quite a high number present as an emergency. So as in pitch up to the SCU with bowel obstruction or an acute tumour. And the diagram, you may well remember seeing this sort of theory of the adenoma to carcinoma sequence. The earlier you get it, the easier it is. We have polyp cancers that are removed at endoscopy and the patients go home and that's their treatment done. There's a lot of surveillance, but actually that's them done. And that's fantastic. Next slide, please. And so my brief is to talk a little bit about NICE and the BSG guidance. And I think if we just look, so NICE, the main thing to say, I think at the moment is that their formal decision, their position statement on FIT is pending. So hopefully, I believe Arnie said over the summer. So hopefully towards the end of the summer, we'll have a decision on that. But what do we have so far? So we've got these referral criteria, which I don't need to go over this really, you know this very well, but there's the sort of the NG12, DG30, and you can go to the next slide. So NG12 sort of high risk symptoms, DG30 slightly lower risk symptoms. And these are the symptoms for which you ask your patients or the patient's volunteer, and then you refer them on a 2-week wait or, you know, an urgent suspected cancer pathway. Next slide. And what's this sort of based on? And it's kind of this sort of action criteria of a positive predictive value, if you like. And that's set at about 3%. So the ability for a symptom, if you've got that symptom, are you going to have bowel cancer? You actually look at these symptoms that are included in the NG12 criteria and actually look at their performance, and it's not very good. So if you've got someone coming to you with diarrhea, the positive predictive value, the ability of that to sort of say, well, that person's got cancer, is 0.94 to 1.5%. So it's not really that great. Change in bowel habit, again, a little better, closer to that sort of 3% number. And symptoms such as rectal bleeding and anemia, they just go above that. But you know that, therefore, having just those symptoms of constipation, you've got that's about 0.4 to 0.8% positive predictive value. So to say that that person's got bowel cancer or not. Next slide. And so therefore, we've got a whole load of symptoms that we ask our patients that actually don't really help us particularly discriminate whether they've got the disease that we're worried about. And so therefore, how do we sort of discriminate? How do we take every patient in your practice who's got some of these symptoms and work out whether we need to send them to the JR or to the Royal Berks or to Wickham for an endoscopy? So that's going on at one end. And then if you look at the secondary care level of what's happening there, so we work in the NHS, it's sort of finite resources, we all know that. And endoscopy is a resource. And if you look at this graph here, and basically this is demonstrating the effect of lockdown on the numbers of endoscopic procedures undertaken. Now, this is colonoscopy, ERCP, OGD, and flexi-cigs. But I mean, it's really quite catastrophic. You look at that drop off. And so there are big backlogs. So the more that scopes that we're doing that, if you like, unnecessary, and I don't like to use that term because no one wants to refer for an unnecessary test, but the more that we do, the more that we're straining a system that's got a backlog. So that's the people who then can't have their polyp surveillance scopes, their ulcerative colitis surveillance scopes. So this is a strain system that the last sort of 3 years has put incredible amounts of strains on. So how can we discriminate better? If we can have the next slide, please. So if only we had a test that could perform and do that, and hence we have FIT. And so this replaced the old fecal occult blood test, and it performs better. It's more sensitive and it's more specific as well to sort of human blood. So fecal immunochemical testing, it's an antigen antibody reaction to human hemoglobin in feces, and it can be set at different thresholds. So you can actually quantify it. So you can give sort of a negative result, or you can give an actual quantifiable figure, and you can set those thresholds. So for instance, again, diverting ever so slightly, if you look at bowel cancer screening, you could, if you had unlimited resources, you could set the FIT threshold at 10 and scope everybody who's positive. Or if you have very limited resources, you can put that threshold up. So there's a sort of a sliding scale you can work with there. Next slide, please. And then we know, and this is from the NICE-FIT study a couple of years ago, that we know that this is good at detecting cancer. So this looked at 10,000 patients referred under the 2-week wait rule. So these are symptomatic patients. These are patients who've come to their GP saying, I've got change in bowel habit, I've seen bleeding. And they used a slightly lower FIT threshold, but we can talk about that later. And actually, the positive predictive value for colorectal cancer was 8.7%, and its sensitivity is 97%. Next slide. And if we then, was there another? Oh, done. I meant to have another slide that just goes back to that table, because if you compare that positive predictive value of almost 9% compared to what we're getting with just asking the patient, do they have diarrhea? It performs sort of basically about 3 to 5 times better than that. So this is a better test at detecting bowel cancer, quite simply. And so then quite a lot of work has been done, and this is from Brian Nicholson here in Oxford, and they looked again at around 10,000 patients and started to look at, the numbers, what's its ability to detect cancer, but also, how many, and useful, you can get a lot of useful information from this. So how many people do you need to scope to detect one cancer? And actually, with a FIT threshold of 10, if you do 10 colonoscopies, you'll find a cancer. And I think the all important thing that we've got to look at here is then, what about the missed cancers? And this is the thing that I think we all worry about. And we all worry about not referring someone because, are we going to miss something? And actually, that miss rate with a FIT threshold of 10 and also with 7 is 1 in 1,000. So out of 1,000 patients tested, you've got a negative FIT, you will miss 1 in 1,000 patients with cancer. And I think that's quite important because that's quite a low number. And if you look around your waiting room and you look at a whole load of people, there, a 60-year-old chap who's there in your practice with maybe a chest infection or a flare-up of his COPD, at age 60, his risk, without any symptoms of having bowel cancer, is about 1 in 1,000. So actually a negative FIT test pretty much puts you at equivalent of the same patient with no symptoms in the waiting room. And that's, I think, very, very reassuring. And so that performance is pretty good. And you can also put that into context with, because what are we referring for? We're referring them to have a colonoscopy. I mean, there's actually a miss rate with colonoscopy as well. There's a phenomenon of post-colonoscopy colorectal cancer. And I mean, there are various studies on that, but that at 3 years can be anywhere between 3 and 7%. I always find that slightly terrifying, but actually you've got a test that potentially is only going to miss 1 in 1,000. And I think these are really reassuring things when you're faced with otherwise asking people some questions that are not good discriminators. So hence, this is the sort of the rationale for this FIT 10 threshold. Next slide, please. And so the BSG guidelines, which are basically putting FIT at the front of this process, what was the background to them? Well, the background is all of this research coupled with COVID, the shortage of endoscopy places. And so a working group was set up, and it was actually quite a big group. There was both surgeons and gastroenterologists. So we've got the ACPGBI, and also, so that's the Colorectal Surgical Society and the British Society of Gastroenterology. And importantly, there was a lot of input from NICE as well, and also from NHS England. And the focus of this was in symptomatic patients. So this isn't about bowel cancer screening. It's not about using it for someone who, had polyps 3 years ago. Should we do another colonoscopy? This is about symptomatic patients who are coming in with these NG12 symptoms that would otherwise be going straight for a 2-week wait referral. Next slide, please. And so here is the flow chart. So the recommendations are that we should be doing a FIT up front and a FIT level of greater than 10. So therefore, that positive, you get referred on for urgent investigation on a colorectal cancer pathway. And then FIT negative, and I believe Arnot's going to talk about that as well. There's either the option of reassurance versus safety netting. And I think, Arnott, I believe you're talking about that. So I won't go on too much about that. If we go to the next slide. So really, as I said, this is the main guidance that FIT with a threshold of 10 should be used in primary care in patients with suspected colorectal cancer. However, there are a few sort of caveats with that. A patient should not be excluded simply on the basis of a negative FIT. So there still is the option, if you are concerned and if there's any reason on the safety netting or any worry, you can still refer in. It doesn't need to be done if someone's got an anal mass or an easily palpable rectal mass or anal ulceration. You don't need to do FIT because that patient needs to be seen. It is very useful in abdominal mass because that's another reason for for urgent referral in. And actually, it can be quite useful because if you've got someone with a palpable epigastric mass and they're FIT negative, you may just go straight and do cross-sectional imaging, get a CT scan. Whereas if the FIT's highly positive, a colonoscopy is likely to be more useful, because there's a bit of discrimination there potentially between other sorts of solid organ malignancy versus whether this is colorectal cancer. And I think FIT, and this is the other great thing about FIT, it also performs well in the DG30 symptoms, so low risk symptoms, versus the high risk symptoms. So there's equivalence there. So it doesn't matter if the symptoms aren't as, the acuity isn't as severe, it performs very well. It also performs well in rectal bleeding. And I think this is really important, because initial guidance was, well, if they're bleeding, don't do it. But actually FIT is detecting hemoglobin within the feces. So actually it does perform well. And I think this is really, really important. And I think if putting this from, because a lot of this, I think it's, I'm working in secondary care, I see 2-week wait patients. I also triage and manage a lot of our proctology patients, which actually make up about 75 to 80% of our referral workload, and they fill our clinics. And as such, with all the pressures and the backlogs that are going on in the system, proctology waiting lists are going out and out and out. And this is a real problem that we're desperately trying to address. We're trying to streamline pathways. However, if you have a patient with rectal bleeding, it seems like it's hemorrhoidal or maybe simple fissure, but they do need a secondary care opinion. If they've got a FIT test, if that's positive, then they should come down an urgent route. Whereas if it's then negative, we know that we can, if they are waiting several months for their appointment, or if indeed their symptoms are minor and are settling down, the patient can potentially be reassured. And it also helps us discriminate between, if they've got a negative FIT but bright red rectal bleeding, we can always book them for a flexible sigmoidoscopy with a surgeon, and they can get banded and potentially treated as a bit of a one-stop shop. So I think it's really important to know that this test works well in rectal bleeding as well. And given how things are at the moment, that's really important. I think next slide, I think that might be all my slides. Perfect. So is that okay, Anand? I think the danger is you give a surgeon the platform and we talk forever. So
yeah, no, David, you did really well there. I think you made a very good case of why FIT is really useful, and the threshold itself with the guidance as well. You stunned everyone except for Kabir. Kabir, you've got a hand up. Please ask your question.
Hi. Thanks, Anand. Thanks, David. David, really quick question. So I looked at the data from London, which set a FIT threshold of less than 2, which looked at the rectal bleeding patients. And a lot of the rectal bleeding, I think it was about 50% of them, despite presenting with rectal bleeding, had a negative FIT. Now, I suspect that's probably because the rectal bleeding is intermittent, and so the samples collected were probably negative for it. I just wanted to make sure that was the reason, because from the way FIT works, I don't believe there's any way to tell where the bleeding is. So if you have a positive FIT, it could be colorectal cancer, so anywhere from the colon till the anus, and it could also be, the other question was, could it be upper GI as well? So should all patients with a positive FIT, if their colonoscopy is negative, be having endoscopy as well?
That's a very good question. I must admit, I don't know the performance in terms of upper GI cancer. I know that our thresholds then are usually looking at anemia before we go on to upper. That is a very good question. That, I'm afraid, is beyond me. And I don't know whether you know anything about the performance in upper GI cancer.
No, but what I do know is that actually this does need to be investigated, because it should not be there. So if it is positive, over 10, we use these terms interchangeably, okay? But we all know what we mean. It's easier to say FIT positive rather than FIT greater than 10, right? So with FIT positive and colonoscopy and lower GI investigations being normal, then yes, it has to be followed through as to where in the GI tract this has become positive. So upper GI investigation would be, in my opinion, probably very sensible and reasonable to carry out. So I don't think we have data on that front, but it certainly would be requiring upper GI endoscopy.
And we know that from sort of positive FITs that, you've still, and by positive FIT, I mean a FIT 10, that you've got to scope 10 people to find a cancer. So therefore, there's going to be a lot of negatives. there will be the other pathologies there. So we'll often maybe, and FIT isn't necessarily, it's not geared and not being trialed to testing for non-cancer pathology. So it's not a discriminator for IBD, colitis and polyps, diverticulitis, but you do often find other pathology there, just not cancer. But the key thing here is that the studies have actually been geared towards cancer itself.
Kabir, you still got your hand up?
Yeah, just another quick question, David. Sorry for taking the time. Just about, you sometimes come across patients who've had a colonoscopy and then represent with symptoms. Say they've had a colonoscopy 2 years prior. From the diagram of the adenomas and the polyps and how they develop, presumably most cancers, and obviously nothing's ever absolute, most cancers do small polyps. So can we be not fully reassured? Obviously, every case is individual, but if someone's had a colonoscopy, say in the preceding few years, up to 3 years, I mean, for example, in which case would you consider rescoping them after they've had a recent colonoscopy? And when do we need to be worried or can be reassured by a previous negative result?
I think what's quite useful is if you, it depends on your suspicion with their symptoms. So if it is something like, for instance, anemia or weight loss or a real convincing change in bowel habit, I think re-referral is reasonable. Certainly repeating the FIT, I think, is very sensible. There is, as I mentioned, there is a miss rate with colonoscopy, and therefore sort of follow up on that is something that we occasionally do, with significant symptoms. I think, given if they're still a year later still complaining, I think it's certainly reasonable to consider that. I think if you do a FIT beforehand, again, if it's positive, there's your sort of answer to go straight ahead and refer. But if it's negative, but you're worried, I think certainly referral and consideration of further scope is certainly reasonable. If you've then, because there are the pathways that exist for investigation of diarrhea, etc. So, is it something that needs to go down that route of the excluded microscopic colitis, bile salt malabsorption, so all that, and celiac disease, all that side of things as well. But if beyond that there's still concern, I think repeating scope is not unreasonable. We see it periodically, but there is, as we know, a sort of a miss rate with colonoscopy, but it's pretty low.
Thank you, David, and thank you, Kabir, as well, for the questions. The time is moving on, so we're going to swiftly move on, but please put your questions into the chat box. That'd be really great. Want to introduce Zahid now, who's the senior data analyst for the Alliance, who's going to tell us a little bit more about some FIT data at the Alliance. Over to you, Zahid.
Yep. Can you see my screen, Anand?
Yes, very well.
Okay, thank you. Thank you, David, for the background information about colorectal cancer. What I'll do, I'll quickly run through a couple of slides. It is only about the FIT data, and more importantly, it is only mainly TVCA and other alliance level. So the first slide, you can see this is a comparison. It is operational performance indicator, and there are a couple of metrics at the left side, and on the right-hand side, you can see there is region and all alliances name. And this is our TVCA alliance over here. So from the first matrix, you can see percentage of people with lower GI 2-week referral accompanied by FIT update. So for May 2023, it is 43%. But if you compare with other alliance, although it is amber, it's a bit higher, we're 43. And when we see the cumulative figure, it is around 63%. Is still a little bit lower than other alliance. And about the colonoscopy on, percentage of colonoscopy performed less than 10, it is 0%. Although if you see the other alliances, there are some percentages over there, but for TVCA, it is 0. Okay. So next on, this has been taken from national team. It is referral with colonoscopy at TVCA region. So you can see from this figure on the top, TVCA's uptake is really low compared with other alliances. One alliances, there is no data, but obviously, TVCA is very low compared with other alliance. The reason is, if you see explanation about this one, only GWAs we get data from, for colonoscopy data. The other three trusts, BST, OUS, and RBS, they did not submit any data in this period, August to October 2022. And I checked the recent data period, and there is no data at TVC at all about the colonoscopy. And next couple of slides, it is all about the feed data at TVCA. Every month, all 4 trusts submit feed data to us, TVCA, and I prepare some analysis, based on the data. So the first one, you can see the feed test completed, the whole TVCA. It is in April 2023. It is feed test recorded yes is 700 and no is 139 and not records 72. So the number of referral with a feed test, completed, whether it is positive, negative, there are some blank awaiting result is one. You can ignore that. So the positive number is 600, and negative just around 100. There are some data. CCG level, and this is the referral with feed, whether it is it completed or not, by practice level. So you can see there are a couple of practice TVCA region, for very high feed completed. And the most importantly, the outcome, is split by feed result, whether positive and negative feed result and outcome. When it is positive and the outcome cancer diagnosis is 2.4% across the TVCA region, and no cancer in this month. April 2023 is around 40%, and trust. There are lots of blank record. We are working with that for data quality with the trust. There are lots of blank record, blank coded, and it is 30% around that. And so, and this the same type of analysis is by trust level. This one is by GWAs. You can see, over the outcome is split. They, they coded negative and also the cancer diagnostic information. There are some trusts like OUS. There are some data quality information, data quality issue. We are working with the trust and improving this data return. Hopefully, this will helpful for better decision or something like that. That's all from my end, I think. Yes. Over to you, Anand.
Yeah, no, thank you very much for that. That's really useful. I mean, it's quite interesting to hear that quite a low number of cancers are found even with the positive fit. So that's really quite useful following colonoscopy. So yeah, we'll hear from other trusts, I'm sure, once you've got your data analysis carried out and quality looked at. Gloria, can you put the slides back on again, please, for the presentation? I'm loving seeing Alison Law's hand there on the videos. It's lovely. Gloria, can you put the slides on, please? That's great. Okay, so we're going to talk a little bit about, and you probably need to go to slide 18 or 19, please. Great, thank you. So we've heard from David about the benefits of using FIT, and really it's all about early stage diagnosis, because actually it's about good outcomes, you know, improving survival rates, early diagnosis, successful treatments, in some cases even a cure, and obviously patient experience and reduced treatment costs. Next slide, please. So when we look at the early stage, and this is a graphic from Cancer Research UK, which is fantastic, will survive their cancer 10 years or more at early stage. If it's late stage, less than 1 in 10 survive 10 years or more. So pretty obvious here, really, that early stage diagnosis is absolute key in bowel cancer and in all cancer, obviously, but in bowel cancer, really crucial. Next slide, please. So this is the Thames Valley Cancer Alliance pathway, which hopefully all of you know about. And in fact, majority of the areas around the UK are using something very similar. And I have to paraphrase this with best practice time pathways. The pathways will be in similar form, but they may change taking into account some of the faster diagnosis issues. So patient presents with bowel symptoms. The pathway suggests, according to NG12, that if the patient has the relevant symptoms, the GP has to carry out a FIT test and a variety of blood tests as well. And including that in our pathway is for the GP to assess their performance status. A FIT test doesn't need to be carried out in ulceration of the anus or rectal margin and can be referred in. Now, if the FIT, as we heard, is greater than 10, then please make the referral on the 2-week wait pathway. If it's less than 10, then consider the patient carefully, and we'll come on to that in a little while. But if there are alarm symptoms, if you're still worried about the patient, then you can actually either refer the patient in or ask for further advice and guidance. But this in general is the pathway. Just a reminder that the bowel screening FIT threshold is greater than 120, which is obviously much higher in this case, but we are trying in both systems to try and pick up cancers early. Next slide, please. So we heard a little bit about the next steps about FIT testing and what happens with thresholds. And the stunning feature here for me is that if a FIT is less than 10, then you need to carry out 148 colonoscopies to find 1 colorectal cancer. So 148, that's roughly 25 or 30 colonoscopy clinics. So patients are going through this when other patients who probably needed it were being delayed. So it's a really important aspect to remember that the FIT negative value is very important. And the positive predictive value of less than 10 is 0.7%, which is actually less than the actual general population prevalence. So it's quite interesting that FIT is really, really a very, very good testing tool. Next slide, please. So no test is perfect, we've heard, and this slide actually demonstrates this further, which is CA125s, nearly 23% of cancers are missed with a level of 35 over 35. PSAs, nearly 25% of prostate cancers are missed. Chest X-rays, we know from studies published that 20 to 23% of cancers are missed. But look at FIT, 10% of cancers missed if the threshold is 10 or more. So FIT is a very, very useful test and a very, very powerful one to actually try and predict whether the patient may have cancer, who will go on to have investigations to exclude cancer. Next slide, please. And the risks of colorectal cancer, again, David covered some of this. The risk of colorectal cancer in a 60-year-old with abdominal pain and change in bowel habit, those are the 2 features he mentioned, 1 to 3%. Risk of colorectal cancer in a person with a positive FIT is over 10%. And the risk of colorectal cancer in 60-year-old without symptoms is less than 0.2%. So really, really quite important here that FIT test is actually a really good tool, good message here. saying to actually try and predict whether a patient may have cancer, because the risk of colorectal cancer with a negative FIT is less than 0.2%. So these are really key messages that you should take away with you today. Next slide, please. So what do you do for a patient with a result that is less than 10 of FIT testing? Well, the suggestion from the Alliance here, which again is pretty much reasonable in all areas in the UK, is for the GP to review and reassess the patient at 4 to 6 weeks and consider other investigations like further X-rays, ultrasound, and certainly do a CA1 to 5. There is also, and I'll explain in a little while, the suggestion to do a second FIT test, but only if clinical concerns remain. And there's a study which I'll go into in a little while, which demonstrates the benefit of doing a second FIT test. Obviously, safety netting is key, and I'm going to talk about that in a little while, whereby we explain and ensure the patient understands and actions are taken correctly. But obviously, if you're still worried and unsure and want to manage the patient's symptoms, but they don't have alarm symptoms, you can refer them through the non-site specific pathways, the old MDCs and RDCs. You can ask for advice and guidance, and majority of trusts respond within a few days, or you can send them into an alternative pathway, and some areas may have rectal bleeding pathway, iron deficiency anemia pathway, or obviously gynecology and urology, either is routine or urgent. So actually, we can still manage the patient appropriately without actually sort of not doing anything. And this is where the safety netting is key. Next slide, please. So this is the evidence about the second FIT. Now, this is a study that was published in BMJ Open. Next slide, please, which looked at around 30,000 patients. Click next, please, whereby they reviewed 30,000, no, go back again, sorry, whereby 30,000 patients were reviewed. And those people that had 2 positive FIT tests were found to have about 5.5% of those patients were found to actually have colorectal cancer. It may not show up on this presentation, but those people with 1 negative FIT test and 1 positive FIT test, this is roughly 4,500 patients, only 23 colorectal cancers, which is 0.5% of patients were found with colorectal cancers, and with 2 negative FITs, 0.04% of patients had colorectal cancers. Click next, please, Gloria. All right, and we missed those 3 other charts. We're going to be circulating these slides to everyone, so we'll have the full set of slides. But the message there is that 2 FIT tests are really quite important, because 1 positive, 1 negative, 0.5% of cancers will be picked up, and 2 negatives, 0.04, which is less than the population. So that's about the negative FIT and the 2 FIT tests. Now, the 23-24 IIF and FIT scenario here has been reviewed by the NHS, and a personal care adjustment has been added in so that PCNs are not incentivized to refer when there is rectal bleeding and to include FIT testing. So that has now been taken out. But really what is required here for payment is a FIT result to be recorded in the GP notes before fast track referral, 21 days before. And the payment thresholds have actually changed from 45 now to 65 to 80%. So you'll get a maximum payment if you hit 80 and over, but the minimum required is 65 for any payment at all. So this is quite a good incentive in a way for good practice, actually, as we've heard. And we know also, and that includes the other 20% in that 80 mentioned here, is that the FIT test is not appropriate when a patient does not consent or return the kit, or if there is anal or rectal mass or ulceration. So that's quite a useful guidance here, which actually should incentivize PCNs to make sure that their member practices and clinicians are including a FIT test, carrying out a FIT test before making a fast track colorectal referral. And obviously the alliances will be there to actually help if there is a kit problem in any way. Next slide, please. One of the key things that I found when I've looked at various areas and audits carried out is that there is a rejection of FIT tests. And really this is because the FIT samples have not been processed. And the guidance here really is that the FIT test will not be processed if there is no name, no surname, no NHS number, and no date of birth on the tube. They need at least 3, if not 4, identifiers. I've also found locally that the wrong tube has been used, and that's the blue tube in the middle where there's a cross there. You need to use the right kit, which is the green one, certainly in our area. And sometimes some of the samples have been received without a request form, or the tube is unlabeled. So the tip really that I'm giving you here is make sure the form is with the actual request kit, and print off a label as you would do on blood tubes, and put it in with the sample, or put it on the tube. Occasionally, very occasionally, the container is overfilled. I mean, I find it difficult to understand how it's overfilled, because it is really a stick which you just dip into poo. But anyway, that's one of the reasons why it's been cited. So please tell your teams at the practice that this is really important to get right. Next slide, please. Safety netting. I'm going to whip through safety netting because we've covered some of it already, but it's all about making sure that you put in processes and actions within the practice using either IT systems or patient advice. You need to record what you've said and the type of consultation you've had, and what safety netting advice you've given. And this is about giving the patient clear advice and next steps following the consultation, but also making sure that the patient contacts are up to date. Next slide, please. Now, specifically, what I wanted to mention here is that there is a reason why the patient's got some symptoms. And really, if the FIT test is negative, then you want to make sure that you're excluding other pathology like renal or gynecology. Since there is a very low probability of less than 10 FIT signposting to lower GI cancer, it's really important to try and work out what the symptoms relate to. And certainly in palpable mass and iron deficiency anemia, those are clear factors, as David said at the beginning, to make sure the lower GI cancer has been excluded. I mentioned the fact that really review the patient at roughly 4 to 6 weeks. Next slide, please. And certainly, please refer the patient in if GI symptoms continue, regardless of the FIT result, because we want to make sure that we're not missing a cancer here as well. And excuse the pun, but never ignore the gut feeling. You know, GPs are great clinicians, actually. They're very good. Please refer the patient in on an alternative pathway if necessary, which is the actual non-site specific RDCs, or even via the urgent suspected referral pathway, even if the FIT is less than 10. Now, one key factor here is consider the patient factors and performance status. Next slide, please. When we talk about performance status, we're talking about patient factors such as their ability to continue daily tasks and activities, which is obviously related to age and their health status, comorbidities, and in fact may even be at the stage of cancer or other illnesses they have. And this is really important, because can the patient actually undergo any invasive assessments and treatments? So biopsies and surgery, you know, the diktat of do no harm really applies here. You know, I would question anyone referring in an 80, 90-year-old who has got poly sort of diseases going on, multiple pathologies going on. Why are they going to go through any of these things? They won't be able to go through these things. So please consider the patient very carefully. And also, of course, there are the complications. The risk of colonic perforation during colonoscopy is 1 in 1,000. Now, you could say that's quite low, but actually to that patient, it matters. So assess the patient carefully. And significant bleeding is up to 2%. So again, complications are really important. There are some patients, because of their health issues and health status, may not be able to get onto the table or even be able to stay still to actually have the investigation carried out. So please consider that. So really what we're saying about performance status here is that it helps us to ensure that the treatment plan is appropriate and individualized. Very important, because we know that with poor performance, there is a high risk of everything. There's a high risk of complications, high risk of modalities which actually will lead to longer recovery stage and may not be suitable for aggressive treatment. Whereas we know that good performance status means that they'll tolerate testing and treatment, they recover and rehabilitate better, and also, of course, may be more suitable for aggressive treatment. So performance status in certainly lower GI and in all cancers is really crucial and important to consider. And next slide, please. So really, I mean, the performance data, there are various tools you may have in your system, which is the ECOG tool or the Rockwood or World Health Organization tools, and you can actually make sure you complete it and write it down on the form. But at the end of the day, it's all about the patients, and we need to make sure the patient understands the reason for the referral and appreciates it, understands, and notice I've written benefits and risks, because the benefit is early diagnosis, but we want to make sure that the risks they go through, they're aware of as well. They also have a choice of treatment, so make sure that's available and explain to them, and with secondary care we'll probably go through. And safety netting, as I've explained earlier on, is absolutely crucial so the patient is not missed. They understand the reason for attendance, they understand the reason for the fit test, and they understand what to do if things don't progress the way it was supposed to. And finally, the crucial thing is, please complete the referral forms very fully, because secondary care need to make a triaging assessment of what the next step in intervention should be for that patient. So that really is a little bit of a run through on some of the primary care aspects. Next slide, please. So any questions or any comments from anyone at all? You're a very quiet audience. You're either having lunch and just not listening, or we've stunned you. David stunned you. Go on, David.
I just want to add, thank you so much, Anne, and that's such a good point about the sort of the performance status of the patient, and are they going to actually go through an operation? And you know your patients a lot better than we know them. The caveat to that is that equally we're in a position to describe what a right hemicolectomy or an anterior resection means. So I think certainly if you're not sure, we're always happy to see. But I think in those patients with multiple comorbidities who you don't feel are going to get anywhere, we're always happy to discuss them. But you know, do they need to start down that journey? Because once it's started, it's often difficult to stop.
Right. Any questions, anyone, or any observations? Was that a useful sort of run through? Was it not so useful? Do you know it all? They've all switched off, David, I think. Okay, well, next slide, please. So one of the things that I wanted to share with you today is that the Red Whale Handbook and Gateway C, as well as CRUK, has some amazing information actually on cancer specifically, but certainly lower GI and fit testing. These are really good resources. They will help you understand it better and also actually help give you points for your appraisal. So really crucial and really important to have a quick read. Please share these resources with your teams. And finally, survey, we need a bit of feedback on today's presentation. You'll find the sort of, oh, it says prostate on there, Gloria. You'll find the sort of QR code there, and forms will be available and close on the 15th of June. So please complete those if you can. Really useful for us to actually understand what we need to do better next time. And Gloria, thank you for today. You've organized it really well today. Any quick queries or questions or final observations, anyone? Okay, in the history of the Thames Valley, it's never happened before. 10 minutes back to you and your lives. So thank you all very much for coming. We will forward on everything to you. It'll be on the website, actually, I think, Gloria, isn't it? It's going to be on the website, the presentation, so that people, and the recording, so people can look at the Thames Valley Cancer Alliance website. Someone's made a comment, so I'm just going to read the chat. What does it say? Jennifer Hayes says, thank you for the summary. Difficult in that some of these sessions can be a bit like we are being told referrals are too much and stop. You know what, Jennifer, I think you're absolutely right in your observation. Apologies, it's not meant to be in any way like that. I'm a GP myself. The idea about today's session was really to try and make people appreciate the benefit of FIT and actually when to use it, because I think there still is a little bit of misunderstanding about the use of FIT. But you're right, and apologies for that.
Yeah, and I second that. We'd never, you know your patients. got vast clinical experience, we will always happily see people. I think what this does is it just helps push you down which route you're going to send them. I think that's the key thing we're always happy to see.
Jennifer, you've responded again. Jennifer, do you want to put yourself on mic and explain what you're saying? Maybe you can't. Okay, but or maybe you can.
Sorry, I'm full of cold, so a bit. Yeah, I think that has been my only comment would be that often these sessions, and it's not just today, is just that there's a, and maybe that's my state of mind in the world of general practice, but it feels quite like it's, how do we put referrals off? It's not all straightforward. We are all trying our best and following the guidelines, but it isn't as, you know, straightforward like that, I guess. And sometimes it comes down to patience as well. And you know, I think that's particularly with the scan requests and things like that. Obviously, that's not relevant here, but you know, sometimes it is good to get a negative scan, and we know that that's what we're going to get, but it's for the patient, and it helps us have those discussions.
So Jennifer, I think you've made a really useful point today, actually. I think it's been a really valuable contribution from you. I think we are overwhelmed, right? And we have to manage the patients because they see us and we're the front door of everything, right? So, and I think you're absolutely right in everything you said. I think the point about this session and previous sessions is not, you know, I'd be the first one to say, this is not about not referring. This is about managing the patient appropriately, and that's the key here, really. You know, early diagnosis is the key, which is putting the patient at the center of it, because, you know, when we miss a cancer, and, you know, all GPs will have in their lifetime, could have missed a cancer, may have missed a cancer, we wouldn't sleep at night, right? We wouldn't sleep. We will blame ourselves, we'll feel guilty, and we'll feel terrible for that patient. So the use of the FIT test is to try and assess the patient appropriately and to have an answer for those symptoms. Now, if it's negative FIT, then follow the FIT negative pathway, which I shared with you, because we still need to drill down and find out what's going on. And I know David James and other trust clinicians will never say no when you contact them and say, there is something I'm not right with this patient, help me, tell me what to do. And you're right, we are putting the patient at the center of it, which is what we want to. So I hope the presentation didn't say don't refer, because that was not the intention. The intention here was to think as we do, and David is absolutely right in that GPs with vast experience and training have a really difficult job to do, and these tools help to sort of triage up what's next for the patient in primary care. So, you know, forgive the message. The message wasn't about referrals. The message was about do what's right for the patient for early diagnosis. Yeah. David, I don't know if you want to add anything.
Yeah, completely agree. And as I think I said to you the other day, Anna, that when I see a patient with abdominal pain on SEU, they've been seen by about 3 people. They've got all the bloods. They've probably got a CT scan, and then I can look very clever and get the diagnosis. And I think that I couldn't, and to do that at the very front line, I've got nothing but admiration. And I think that the way I sort of see it, and I use FIT as well. So if I've got patients who have maybe they don't really meet, they're in my clinic for something or other, and they maybe don't meet a criteria for a colonoscopy quite, and I will still use it in that setting because I've missed cancer and it's a blooming horrible feeling. And this, I think it does give you a good reassurance. And I think hopefully when NICE come out with their guidelines, I think then it's good to feel that you're getting backup, not just from what we're saying, but actually a good official NICE guideline does give you that sort of reassurance, which I think is important. But you're exactly right. And again, I do exactly that. I have patients who I will order CT scans on from clinic Well, and I know it's going to be normal, but then you're looking at a patient who's got something going on. You're not quite sure, and some of it is patient driven. Some of them are very happy. They just know that fits negative. I'm happy. Some of them aren't, and you've got to manage them. You've got to get the flow of your patients through, and we're always willing to help that, definitely.
Yeah, thank you, Jennifer. Does that sort of give you a bit more reassurance?
That's really helpful. And I mean, I love a fit test. I do probably, I don't know, several every day. So, I do actually, when it comes to the fit, it definitely is. And it is really, I have found it really helpful in terms of discussing it with patients if they have got, we suspect piles, but then we can do a fit and, get a negative, and then it just adds to that reassurance. Absolutely.
So my take on this, and a final sort of session, I suppose, final comment really, is that if it's a negative fit, I wouldn't want to miss another serious pathology. They could be renal, they could be bowel, they could be sarcoma, they could be other things that's causing the symptom. So that's where the non-site specific pathways are really useful. Yeah. So actually just work through the testing and the process is the only advice I can give myself and anyone else, that if the symptoms are still there, you still need to explain it, then use the other pathways. Thank you, Jennifer. That was really useful interaction from you. Really grateful for that. And I was going to give you 10 minutes back, but I think the last 5-7 minutes have been really useful as a discussion. So thank you all, and keep well. And any feedback, please let us know. Take care. Bye-bye.